Good morning, everyone. We are so thrilled about today's session, which is titled Stories from the Frontline, Clinical and Hospital Responses. As a clinician myself, I have watched this epidemic unfold before my eyes, and I have looked to leaders like those who are on this call with us today, who led from the very beginning. The four people who are joining us have had to manage some of the most uncharted and unprecedented territory, and they led the city of Boston at all levels. And the four people who are joining us today are really personal heroes of mine. And I know as you hear from them, you're going to be thinking, wow, these people met uncharted territory and led huge institutions, community responses, departments of public health, emergency responses, hospital infections, to move us to places where we can contain the virus and remain safe, and kept hospitals open throughout all of this. It is an enormous effort, and this effort is ongoing because the virus is still with us. And so they'll be speaking with that to us today about that issue as well. So I want to be mindful of the time because we have four excellent speakers, and I'm going to move us right to our polls today, where we can ask you two questions that we'd love to get your responses on. So if we can bring up our poll questions, we can kick this off. So the first question is, have you visited a hospital or clinic since March of this year? And the second question is, have you had a dental visit? And then we actually have a third one too, is have you had a telemedicine appointment? So if you can take a minute or two to vote on those, that would be great.
These questions are all relevant to our guest faculty's work during this period. How to keep healthcare going in the face of a pandemic is a gigantic question for us today. So we're eager to see how you've interacted with the medical system since the outset of the pandemic.
So interesting. So we have about a 50-50 split in terms of visiting a hospital or clinic. Quite a smaller number of you have been to the dentist. That isn't completely surprising. And a telemedicine visit is almost at 60%. And I think this really speaks to the shifts that we have seen, certainly in healthcare, in terms of how we have tried to provide care for our patients throughout the system. So I think these are really interesting responses, and I'm going to turn it over to Alan now to introduce our speakers.
Thanks, Ingrid. As Ingrid said, we're incredibly fortunate to have four leaders of Boston medicine. As all of you know, Boston was early and hard hit by the pandemic, and it involved incredible planning and oversight and thinking for our guest faculty today about how to manage in the institutions that they work. I guess I would also say that, you know, we have a tradition in the history of health in the United States and in many places around the world where we've divided up public health and clinical medicine. And one thing the pandemic demonstrated, and again, all four of our guests participated in this, is that the boundary between public health and our clinical care institutions, our academic medical centers, and our public health clinics were all fundamentally eroded and are eroded in this time of the COVID pandemic. So we have four really remarkable leaders, not just in Boston medicine, but in national and global health. Our first speaker will be Dr. Katrina Armstrong. Dr. Armstrong is the head of the Department of Medicine at the Mass General Hospital, and also a title called Physician in Chief. And she has major responsibilities there for thinking about patient care, research, and teaching. She's an expert in medical decision-making, which is a skill that's been in great demand in the pandemic and in quality of care. And it's really great to have her with us today. And she has both the frontline view of an active primary care physician and the broader view of having major administrative responsibilities in the hospital. Our second speaker works closely with Dr. Armstrong. It's Dr. Paul Biddinger, and he's one of the national experts in disaster preparedness and directs the program in disaster preparedness at the Mass General. He had enormous responsibilities and continues to in the response of not just the Mass General to the pandemic, but really in thinking through the national public policy and health issues for institutions who are trying to assist in both taking care of patients and preventing the further spread of the virus. One of our speakers isn't here yet, so I'll introduce first Dr. Claire-Cecile Pierre. And Dr. Pierre is a colleague of mine at Harvard Medical School in the Department of Global Health and Social Medicine. She's a distinguished leader in primary care and the consideration of healthcare disparities and healthcare for people who have traditionally been underserved. She experienced the pandemic in her leadership role as the chief medical officer of Harbor Health, which is a major consortium of neighborhood clinics in the Boston area. And our fourth speaker is actually experiencing a bit of a COVID emergency at Brigham and Women's Hospital right now. It's Dr. Michael Klompus. And Dr. Klompas is an infectious disease specialist who has really focused his career on preventing the transmission of infections in hospitals. And I can tell you, as a historian of medicine, hospitals and infections have been one of the traditionally significant risks for hospitals. And in the 19th century, as these major hospitals like the Brigham and especially the MGH were built, the problem of infections in the hospital was one of the major deficits and problems of hospital care. And it has obviously remained a problem and been a tremendous issue of concern during the COVID pandemic. So we're eager to hear from all four of you. We hope Dr. Klompus can join us, but we'll start with Dr. Armstrong. Thanks so much for being here.
Well, thank you so much for the invitation. I am delighted to join you this morning. Certainly what we've experienced in the hospitals and in the healthcare system over the last, let's say, 6 to 9 months, I think will be the subject of many thesis for history of medicine grads and people interested in history of medicine for years to come. And I think we have so many lessons. So in my 5 or so minutes, what I'm going to try to do is 2 things. I'm going to give you a brief sense of what it was like to be in my position as this happened. And then I'm going to share what I think have been some of the 3 lessons that I carry forward with me as I think about US healthcare and healthcare across the globe as we move forward. So the first I will say is that I think for me, this will always be a series of vivid images of what we were going through as we learned what was happening. And so for the Department of Medicine I oversee, it's about 1,000 faculty, mostly physicians, all of our primary care practices, all of our inpatient services, the subspecialties from cardiology to endocrinology. And so we learned we have in the past thought we might have a pandemic, but this time I would say in March 13th, my birthday, I will never forget, it became 100% clear that what was happening in Italy was going to happen here. And at that moment, we really, and I think this is true for any leader, the fundamental question you have is about people. It is fundamentally about what people are you going to need to be able to respond to what is going on. How are you going to keep your people safe to respond to what is going on? And how are we going to care for our patients, for those who are going to be affected and for those who had chronic disease and other issues that were in active cancer treatment that were desperately in need of healthcare. So we really focused on those three issues. And I will tell you, I think leadership is about people. And so those three issues became central. The first we did was we really moved very quickly to try to understand that to keep our people safe at that time, we needed to consolidate care for people with potential COVID-19 into some areas where we were sure we had the right infection control. So we developed something called respiratory infection clinics, where anybody with symptoms would come in and be seen with people with the right infection control, because we had to keep our workforce safe. We then developed new strategies to train people across disciplines, radiologists, urologists. This won't mean a lot to you, but I will tell you that those people fundamentally believe they can't check a blood pressure once they get that subspecialized. And so we had to retrain people to believe that they could care for COVID-19 patients. We developed a surge team and staffing plan with training to do something that healthcare has never been willing to do, which is to admit that we can actually move between disciplines in healthcare. I think a major lesson for the future of American medicine. And then I will just say, we focused tremendously on how do we do better for our patients. And so I will say there were two main efforts in that I'll bring up, although probably many, many more we could discuss. So the first was, how do we do better for our patients with this new disease? Nobody knew anything about it. Just imagine that. Just imagine that you were going to have hundreds of patients that nobody knew anything how to treat. So we had to stand up very quickly committees bringing together the best expertise to figure out the right treatments, to bring together new data, to make evidence on the fly about what was the right way to do this. An incredible experience that I'll come back to in my lesson. Second, we had to figure out how to help the patients who didn't have COVID-19, were not going to be coming to the hospitals and the clinics. And to do that, it became very quickly clear that telehealth was good. Telehealth in every format. Lots of issues, and I'm very much looking to Dr. Pierre's comments about disparities in telehealth access. We learned those very quickly. So we understood quickly that to help our patients, we needed to be able to get them access to their medicines, to their doctor, without their coming to the health system. So I will never forget this experience. Maybe I'll share at some point a picture in the question and answer, because what it taught me, you know, and I sometimes joke a little bit about this, but I would say in the history, one of the striking things to me about the history of the last decades as I've been in medicine is that when I talk to medical students or I talk to anybody thinking of medicine, they somehow think that there's no problem in changing the genome to cure cancer, that we can turn on and off immunology to be able to do all sorts of things. But they somehow have bought the idea that we can't actually change how we deliver healthcare in this country, that we can't provide insurance to those who need it, that we can't change what the jobs are. And I would say the primary lesson that I took away from this is that there's really nothing that we can't do in healthcare. And that the mandate that we can have to change how we deliver healthcare is really, really there, and that we can rise to this occasion. I guess the other lesson that I learned is that trust is critical. I think Ingrid knows that I've been saying that forever. But it turns out when there is that much uncertainty about what is happening, when the data and the evidence are changing so quickly, that leaders need to be able to make decisions quickly, and they need to be trusted in those decisions. And then I think for healthcare, we have let that trust bank, or whatever we want to call it, go down way too low. And that we need to be building up who we are and what we do to serve our communities. And for me, I think about that now every day. And then I'll just leave with the last lesson that I have that I've been thinking a lot. And that is that many times we wonder why we have academic medicine. People have written a lot about why we have these institutions like Mass General, like the Harvard teaching hospitals. And I think for me, this was a crystallization of what that provides to US society. So at a moment of greatest need, what we were able to accomplish was to bring together our science, our educational missions, our clinical missions, to actually develop new paradigms to treat that disease, to link it to communities, to understand evidence quickly of the disparities that was arising, and to move forward in actually changing how we did things based upon knowledge, based upon science, in this incredibly rapid way. The dwell time, the cycle time was something like I've never seen. And so for me, it's almost this crystallization of why we actually have academic medicine and why it can offer so much. So happy to take questions, and thank you so much again for having me here. I don't know if you want me to turn it over to Paul, or you guys want to do that.
Just say quickly, you know, you have presented such a powerful rationale for academic medical centers and the relationship of medical training, innovation, and universities. And, you know, for me as a layperson, it was inspiring to see physicians in hospitals, you know, working so hard during these surges. And, you know, all the questions that have been raised about trust and professionalism, you know, were really in some ways identified by the way in major cities, healthcare workers in hospitals responded to the pandemic. And it's a contrast to all of the problems that we see in responding to the pandemic. So we'll get to some of this. Thanks so much for that presentation.
Maybe I'll just jump in because I want to be very clear. I know you have a number of doctors on this, but the heroes of the pandemic are our nurses. And I just want to be very, very clear that every time a doctor stood up, there were 3 or 4 nurses standing in front and beside them. And so I just want to make sure that that is very clear to everyone.
I think that's such a crucial point. And as we know, academic medicine has historically been extremely hierarchicalized. And one of the things I, you know, take from your talk is the possibility of genuine collaboration among all healthcare workers in ways that, you know, kind of remind us of traditional values that, as you say, have sometimes been eroded. So thanks so much. Let's move to Dr. Biddinger, who was really in the thick of the planning and thinking about how to respond to disasters. One thing I didn't get a chance to say in my introduction was that Dr. Biddinger was a central force in the response to the Boston Marathon bombing and the Harvard and Boston-wide response to getting people who had been hurt so badly the best possible care in ways that saved really hundreds of lives. So Dr. Biddinger.
Thank you so much. And it's really a pleasure to join all of you. Thank you very much for the opportunity. I'm an emergency physician by training and about 20 years out of my residency. And actually that correlates with the 9/11 attacks back in 2001. And that's actually what I wanted to focus on in my remarks is that intersection of medicine and emergency preparedness or disaster response, because really what I'd like to talk about is decision-making in emergencies and effective action. So when I finished my residency, I came to Mass General as their EMS director. I'd worked a lot with ambulances and pre-hospital setting. And when 9/11 happened, although the hospital actually has quite a robust history of taking care of patients in disasters, they noted they really didn't have any internal specialists in disaster medicine. And so over the ensuing few years, that's really the direction my career took. And that's really not uncommon for the US healthcare system. Up until roughly 9/11, most hospitals had emergency plans, but they were pretty much paper plans. They weren't really tested. They certainly weren't evidence-based. A colleague of mine often calls them developed by the Bogsat method, the bunch of guys sitting around a table method. And unlike everything else we do in medicine, really had no connection to data or outcomes. And so what we've seen in the last 20 years is really an evolution of the approach to emergency preparedness and disasters, starting to try and be much more evidence-based and much more outcomes-based as well. And so what I've really spent my career trying to do is figure out what works and what doesn't work, excuse me. And just like you expect a cardiologist to treat your heart condition based on the best available science, you certainly should expect hospital disaster plans to reflect the data that we have as they're created. And the Boston Marathon bombing experience is a good example of that. Most hospitals' mass casualty plans were relatively rudimentary and pivoted around ideas that you get a call from the ambulance service or the fire or the police when something happened. They'd tell you about the patients. You'd make some phone calls, start calling in staff, especially once you had a good sense for how big the event was, and you'd respond kind of along the way. And when you look at it, it turns out that events go much faster than you expect. In Israel, we learned that victims present within 4 minutes to the closest hospital, and all those things you thought you could rely on, like time and the luxury of some thoughtfulness in your decision making, weren't there, and that could cost lives. So we are very proud of our response to the marathon bombing. It's really the same principle we've used in our preparing for biothreats. So for more than a decade, we've been preparing for pandemics, and when we started to hear news of the new coronavirus coming out of China, we started looking at it again, trying to gather all the data we could and see what we needed to modify with our plans. In the first part of our response, and we really divide our response at Mass General up into 3 phases, which was the early information gathering phase, the surge phase, and the recovery phase. It really wasn't clear whether the virus would spread globally, and if it did, whether it would be sustained in its transmission or whether there would be pockets. We had the experience of SARS and MERS, where there have been patients that have traveled around the world and developed either small clusters of outbreaks, or in the case of SARS, larger outbreaks, but that were contained. And so it wasn't at all clear, those are both coronavirus infections, SARS and MERS, whether this new coronavirus would behave the same way. And so between January, and we activated our hospital's emergency plan on January 26th and early March, just before Katrina's birthday, it was really our preparatory phase. We were trying to learn all the lessons we could from what was happening in China, both therapeutically, but also epidemiologically. And we were training up our staff to put on and take off the personal protective equipment as safely as they possibly could. We tried very hard to purchase as much personal protective equipment as we could. We are actually one of the very few health systems in New England that had a cache, a disaster stockpile of PPE, but still, given the shortages we faced, was not as big as we would have wanted it to. And we improved our screening and patient identification plans so that we hopefully would identify any potential cases with COVID as they presented to our healthcare system. And I think that that period from January to March was really a question, an example of how much we had to really pivot from looking at this as a one-by-one presentation of disease to a population-based of disease. We are one of 10 hospitals in the US designated as an emerging special pathogens treatment center. So we have a group of dedicated nurses, physicians, others who are specifically good at caring for patients with Ebola, MERS, SARS. But as soon as the event got bigger, it was clear that we had to expand beyond our dedicated biothreats team, and it was going to require the whole hospital. Katrina mentioned March, and it was actually that week leading up to her birthday that was the most dramatic. On March 5th, as has been reported in the press, a number of patients from a conference held by a biotech company in the area came to our emergency department and said they'd been exposed to what was still at that time called novel coronavirus, soon to be called COVID. We worked with our state health department, tested many of them, but within a couple days after that, we started seeing positive tests coming back quite quickly. And it was very clear that the disease was in the community and that we were on the precipice of an outbreak. And so that surge response from the beginning of March through the end of May, really almost a 12-week period, was I think that the prototype of what emergency planning and emergency management is about, which is decision-making and uncertainty. Again and again and again, we had to question things that were dogma, some of which were not true and some of which turned out to be true. The previous coronaviruses that we'd seen, MERS and SARS, you could not transmit before you had symptoms. And we had to react to data that started to suggest that you could transmit COVID before you had symptoms or maybe without symptoms at all. You know, it's really hard in medicine because a lot of our plans were based on a certain set of assumptions about COVID that turned out not to be true. And so ultimately, when we realized that in fact, absolutely you could be infected with COVID and have minimal or no symptoms, it completely changed how we had to manage access to the healthcare system. We took Mass General, which has 77 doors to the outside world on the main campus, and went to 4 access points managed by our police and security and our nursing staff. We get, on average, 60,000 visitors to our campus every day, had to essentially shut off the flow of visitors that were not screened, and then decide to put a mask on every single staff member, patient, and visitor to try and interrupt the chain of transmission. And that was done overnight in a hospital of 26,000 employees. So these decisions, once we felt we were confident that this new knowledge, which was completely flying in the face of what we had thought before, that new knowledge was really worthy of changing our direction, we had to act quickly. You know, it's longstanding been a dogma in the infection control world that actually masks were only useful in certain infection control or hospital-based settings, and that public wearing of masks was not effective. There was some study about this. And again, there was a time where we had to challenge that assumption, realize that the data we had was incorrect, and move forward. And so trying to constantly be skeptical about what we know, be willing to make extraordinary changes to the healthcare system, such as not permitting visitors, putting masks on everyone, changing how patients flow through the hospital, was really what was required. And I'll draw a contrast with that, a bit of a comparison and contrast with what was happening on the medical side. I think, although all of us know that new diseases emerge, it still is a very strange position to be in when a completely new disease comes out and you feel like you're living history. You know, all the things that you've read about in your medical textbooks when you're in training is now knowledge being generated in the middle of your response. And so there were so many questions about how the lung injury was different with COVID patients. We would see them present and they look like almost any of us on the webinar here, talking and conversant in not particular distress, yet their oxygen levels, when we measured it with an oximeter on their finger, were those of people who were nearly dead or died. And so that discordance between what we normally see in medicine and these patients was extraordinary. There started to be lots of anecdotes about the degrees to which clots were formed or kidneys injury happened, others. And so then there was a lot of early information suggesting we should be doing things very, very differently in medicine than we normally do. We should manage ventilation or intubation, putting in breathing tubes differently, managing anticoagulation. We should give lots more blood thinners to patients, others. There were lots, I think, in the medical spectrum around the globe that sort of, I would say, lurched from therapy to therapy to therapy based on anecdote. And one of the things I think that we did best at Mass General, I want to give Katrina and the Department of Medicine particular credit for this, is really critically evaluate new knowledge in the context of what we already know. We are very proud of the outcomes actually of our patients in COVID in our hospital and want to recognize the tragedy, unfortunately, of so many deaths that have resulted from COVID. But we were very careful to make sure we stuck with what we know until we had good evidence not to. Her group, some intensive care physicians within the Department of Medicine, were publishing a daily letter looking at the new research that was out there, comparing it in the context of existing knowledge. And there were certain things we changed quickly. There was an evidence-based article from Italy showing that prone positioning in awake patients, so normally people lie on their back just like all of us do when they're in bed, but proning them, meaning putting them on their belly, was helpful. Now, we've known this in the intensive care unit for intubated patients for some time. When you're on a breathing machine, it's still a rare therapy. It's not done commonly outside of tertiary care centers, but it's never been done for awake patients before COVID. There were some success stories that taking patients who are critically ill, flipping onto their bellies while they're still awake, actually would prevent some serious lung injury in some subsets of patients and prevented them from needing a ventilator. We evaluated that data. We actually put it into practice within 5 days of it being published in Italy. And it's been a tremendous success. It's something we continue to do. Yet, I think some of these other therapies that kind of came and went as proposals without a lot of evidence behind them, we avoided. And I think, again, it lies behind our strategies. So throughout this pandemic, whether it's how we keep our staff safe, how we use personal protective equipment to make sure that we have the safest possible care environment, how we keep our clinical staff up to date on what's changing in the science, what we need to do, and ultimately how we can preserve access to usual care as well as our ability to care for COVID patients, have been those things that we've had to constantly change throughout the entire pandemic. At the beginning, we were actually ordered by the state to cease all non-essential care, and that really, as Katrina described, created health impacts for a good number of our patients. Now that we've been able to resume a fair amount of medical care, what we're trying to do is learn those lessons. We have to be able to care for patients with COVID, but how can we resume ambulatory care, procedural care, inpatient care, and also, frankly, how can we do it and protect our staff at the same time? Katrina's comment about our nursing colleagues couldn't be more important. I think they did work the hardest, bore this most significant brunt of this pandemic. But I think everyone, and I want to recognize so many others in our system, our environmental services staff, our buildings and grounds, our food service staff, people showed up, and they really, really showed up to help despite a lot of early concerns about the work environment. They've kept showing up, they're still showing up. But we need the whole workforce to be able to come to work, and we need them, frankly, to be able to stay at work throughout this pandemic and beyond. And people are tired enough, and they've been through so much stress that we have to hear from them what they need from us to support them. Learning lessons is not over by any stretch. Of course, we're still generating medical knowledge, but we also have to continue to generate operational knowledge about how to operate the healthcare system in a COVID world going forward.
This is just so important. I guess one of the themes that's emerging in the course that, these talks underscore is the compression of time that is in some ways uncharacteristic of medical innovation, reporting of evidence, being able to make more strongly evidence-based decisions in terms of treatment and protocol in the hospital. And I guess I'm really struck. I've done quite a bit of historical work on the AIDS epidemic. And, from 1981, when the first cases were reported, it was 1985 before a test was widely available. And then treatment was delayed another, 6, 7 years from then. So in some ways, AIDS has certain similarities, a new disease, people trying to figure it out, a lot of uncertainty, stigma, and moral issues. But the compression of how academic medical centers committed to evidence-based practice, that seems to me to be one of the unique aspects of this. And, how one can assess evidence in an emergency situation is different than in other aspects where we've watched the unfolding of knowledge and its application. So I think these are such important observations. Let me move now to Dr. Pierre. And one of the things I forgot to mention when I introduced her earlier is that she is a graduate of the really remarkable bachelor's MD program at Howard University, where students move through their bachelor's training in medical school in only 6 years. And that program has produced many important leaders in American medicine, and Dr. Pierre represents that really distinguished group. So Dr. Pierre.
Thank you. Thank you so much for having me today. And I'm going to start my discussion the way Paul did, sharing a little bit about how my role and my work prior to COVID-19 impacted the decisions, and then highlighting the way Katrina did, the role of us as leaders and our priority being people. So my remarks will be in 3 different buckets. The first one is about really giving you a sense of where our work falls. I'm going to share a little bit about the community health center perspective. So I'll talk about that. I'll then share how the response was challenging, but yet full of lessons for community health centers, and then look at my role as a physician leader, and hopefully some of these reflections will be helpful to others. So I joined Harbor Health as a community health center almost 3 years ago, and as their chief medical officer. And I didn't know much about community health centers until a few years ago, which is really sad because they are basically the public health extension of clinical services in the US. So I'll stop here and say a little bit about them. In the 1960s, a group of community activists and a few doctors were involved in registering people to vote and basically the civil rights movement, looking at systemic racism and its impact on healthcare, and decided they were going to start to fight poverty with health. And the thought was that they would propose this new type of clinic that would be inspired by community-oriented primary care based in South Africa, but offer it right here, because they said there were people suffering right in our backyards, right in the US. And the model was to have a clinic that would have all of the medical services in one place, making it more convenient. So medical, dental, eye, behavioral health, all of the disciplines that you'd need, outpatient services in one place, but also would address social determinants of health. They understood that their patients in their communities were sick because they couldn't register to vote, so they would help them do that. They understood that because they didn't have access to water or transportation or housing, so they had community health workers right in the clinic that would go back and forth. These 2 doctors, Drs. Geiger and Dr. Gibson, decided to then write a proposal to the president of the country at the time saying, hey, going to start this new clinic, may I have $30,000. I'm going to do one in Boston as an urban example and one in Mississippi as a rural example. And the Boston location actually opened first. So they went on and started the very first ever community health center. They actually got more money than what they requested. And out of that grew really a movement that was designed to offer care regardless of ability to pay. This is really important because community health centers accept everyone. We provide care for everyone and anyone. We accept insurance. We take professors. We take students. We take health essential workers. We also take immigrants. We also take others who are in transition in life and therefore are homeless. We see everyone. And the first thing we do is we allow them to receive care with us, regardless of whether or not they can pay us. Most of our finances come, therefore, of course, from insurance and billing insurance, which is the fee-for-service model in the US is probably its own discussion about its limitations. But then also, we receive a small grant from the federal government. Since that first center was opened in the US, there are now 1,200 community health centers across the US, including the Virgin Islands and Puerto Rico. They serve 1 in 12 people, so about 28 million people. They serve most of those who live in rural communities. They serve a lot of people who are under the poverty line. And most community health centers serve more than 1 language. The very first one is still in Boston. It is now called the Geiger Gibson Health Center. And I am now its chief medical officer. Over the years, it has grown to have more than 1 location. So we have 7 locations from Boston to the Cape. And this is where my prior work outside of the US really helped me understand that some of the themes we see when underserved communities, where basically poverty, racism, and other biases meet, can have a huge impact on everyone. My work was also in Haiti, where I saw the cholera outbreak. And as soon as I heard about the pandemic, or COVID at the time, I was really concerned about what we would see, because I was concerned, of course, about what it would mean for everyone, but I was most concerned about what it would mean for the communities that we serve. In Boston, our predominant language for most of our patients is English, but our second language actually varied by region. So if you were in Dorchester, the second language was Spanish. If you were in Neponset, it was Vietnamese. If you were on the Cape, it was Portuguese. So automatically, the second piece of what we had to do was to look back and say, what did I learn for me? What did I learn from our work with the cholera outbreak in Haiti? And it was about communication, humility, and flexibility. I think Katrina and Paul both brought this up. Like, even if you know a lot, you have to stop and study as you go. You have to make sure you stay up to date. You have to make sure you're willing to communicate and share, both internally and externally, as many of the hospitals did, including NGH, and be flexible and supportive to respond as things progress. So within the first few weeks, the second area that I'm going to focus on is what it meant for us, the people working at community health centers and the people that we care for. So for me as a chief medical officer, there were three groups that I was most worried about. One was our staff. Our staff actually by design represent the communities we serve. That was the whole idea, that our staff are multilingual and they live in the communities and so on and so forth. But we knew that communities of color were more affected because their partners, their moms, their uncles, whoever was living with them were also the essential workers and the cleaners and the people working at nursing homes and so on and so forth. And so our staff at the time of this epidemic was, of course, trying to respond at a time when they themselves, their communities, and the people that they care about and their families were most affected. For our staff, we also learned, and I think that was one of the questions on the chat, that the way healthcare is financed, it's fee for service. I mentioned that earlier. And so to keep people safe, appropriately so, we switched quickly to only essential visits, what were really needed, and telemedicine very quickly. So that made sense. But there were two barriers. What that meant was we had less revenue, and I think hospitals were affected too. And so with less money coming in, we had to make really horrible and difficult decisions. We had to furlough about a third of our employees. And so the very people, again, that are most affected, that are ready and willing to serve their communities, are now furloughed and anxious about what it would mean for them financially to continue to care for their families. These were probably some of the hardest days in my leadership role because these conversations were extremely difficult. Our dental team, we had to close their dental practices, so they were basically all furloughed. And our medical teams, we had to ask people to work very hard with fewer colleagues around. So that's for the staff. And what I tried to do in response to this was to stop and remember that this is new to all of us, and actually share and reflect both the anxieties and the fears, but also the hope and the plan. And there's a lot of difficult and, but yet very important role for leaders. So we increased our meeting frequency, we met together, and I made sure that I understood the spirit of community health centers was, again, that we are an interdisciplinary team caring for patients. So all of our meetings were as the entire care team, with the medical assistants, open to others, with the nurses, with the providers, realizing that that staff had to do the part that a lot of us couldn't see on TV, right? The hospitals and the emergency rooms made a huge role. But the majority of people affected with COVID-19 didn't go to the hospital. They were calling us. Our phone lines were just off the hook. And so they were calling us, and our nurses had to figure out and triage, okay, this person sounds stable enough that we can call them once a day and see how they're doing. This person sounds really sick. We would need to call them 2 to 3 times a day. This person's really, really sick. So maybe they should go to Katrina's respiratory clinic or to the emergency room. And so a lot of our work was actually to redesign the way we provide services and to really serve at a time when our financial resources were less. And again, PPE and other equipment was not available. The second group we were about were our patients. And this is where our relationship with the communities and our patients made a huge difference. We knew that we wanted to reach them through telemedicine, and we realized that we all know that video conferencing is not something that everyone is agile with, right? It takes time to learn how to log in, your browser, download the app. If there is no app, make sure that the microphone is off or on, and so on and so forth. So we first just switched on to telephone and then added video conferencing, realizing that we needed to keep a list of some of our most vulnerable patients. And for us, in that group were our homeless patients who may or may not have had a telephone, or our patients living with substance use disorders who are finally transitioning and getting support and doing better. We didn't want them to fall through the cracks. So a lot of our design was to constantly care for everyone, but making sure that appropriate resources and additional programs were offered to those most affected. And then lastly was our community. We knew that all of this was happening in a context where our patients from Brazil were hearing about their families from Brazil who may have been affected, and can their aunt come in? They were just, they were gonna have a wedding, this, whatever it was, right? So now we had to help answer their questions, alleviate their fears, but also think about how to make sure that the larger community understood what the disease was, what it meant, and so on and so forth. It was disheartening to see the public health response in the United States. During the cholera outbreak, as I mentioned, in Haiti, some of you may know Haiti was hit in 2010, in January of 2010, by an earthquake that displaced 1 million people and killed hundreds of thousands. And then 10 months later, had a cholera outbreak. And my role was to work with the government of Haiti and the Ministry of Health and donors who were giving $100 million or more to Haiti to help coordinate their response for the health sector. One of the things we realized quickly was that anything that's new or different is scary, and people start creating their own stories about it. Cholera, I found out, could be, just so you know, it's a waterborne disease, so it's usually in the water that you drink. There's a germ in there, you get sick, it's horrible diarrhea, and then people get very dehydrated and can die. That was it. So you had to stay rehydrated or go to hospital as soon as possible, and most people would survive, but some won't, just like COVID. People didn't know that. They thought it was in the air, so they were closing their windows. They thought it was their neighbor, because it's when at the neighbor's house where they all drink water together that they got sick, so they started attacking people, and so on and so forth. But we had to work with the public sector there to get the messaging right, and it made a huge difference, right? The president and the leaders make the right statements. Have the Minister of Security fly with a helicopter over to a rural town where there's limited communication to say, please stop, this is not how it's transmitted. In the US, it was really sad to see us really fail the public health communication in a way that was consistent, clear, humble, and honest, and based on data and science. That actually had a huge impact on life. Therefore, for us as Community Health Center, that increased the amount of work we had to do. We had to both share the messages in the right languages and counter unnecessary messages and dispel myths. And lastly, I'll end with a little bit about what it's like for me as a physician and leader looking forward after learning about this. I think, these disasters are horrible. And as Paul and Katrina mentioned, physicians play a big role, but really we're just one piece of a larger system. I now see this as something that we're all responsible for, every healthcare disaster, every health as a whole. And I mean everyone in the healthcare system, so every healthcare worker, but I mean every individual. If we look at health as a human right, we must vote appropriately. We must design businesses that provide the right economic support and finances to the staff that we hire, and so on and so forth. So a big part of my role during this time was to get engaged in public health department or state or other advocacy forums to make sure that our voices were heard, but to also make sure that we were able to share with others what we can do moving forward to decrease the disparities. I'm happy to take questions at the end.
Thanks so much. I'm so impressed with the 3 talks and the roles that each of you have played in responding. And I can't help but contrast it with the kind of response, regrettably, we've seen at the national level. And in some ways, there's a saying that's been mentioned a lot in the course of COVID that all epidemics, like all politics, all epidemics are local. And I have to say, all of us as citizens and as potential patients have to admire the kind of ways that so many people have stepped up to try to ameliorate the suffering and displacement of the pandemic. So let me turn it over to Ingrid, and we'll begin to bring some student questions in. Ingrid.
Thanks so much, Alan, and thank you to our amazing speakers. I want to be mindful of the time for our students, and there are questions that are piling up. So I'll just maybe ask one, and then while we're bringing in a student, just to kick things off. I think one of the real hallmarks of what you three were speaking about is both the need for leadership, but also the need for transparency and communication, and that you were fighting both this massive unknown pandemic and also the pandemic of misinformation that is consistent, and it continues to be that way. And so I wanted just to see if any of you, all of you, might want to speak to that role that you had to play in these leadership positions and navigating that process that added an additional layer of communication skills that you probably had to call upon.
So I'm sure Katrina and probably all of us have a lot to share about this. I would say the two principles that helped me the most are one, making sure I can always explain why we're doing what we do. We try and share that rationale as publicly, as you said, as transparently as possible. And that's extra hard in the beginning when you're relying on other principles from other diseases, and of course by definition, the emergence of COVID was a new disease, and therefore we couldn't say we knew for sure in COVID. We could simply say we knew in analogous circumstances. But there are a lot of things I would say early. Personal protective equipment discussions, of course, dominated a lot of the early response, and there were people who very much wanted in our system to wear full body covering, moon suits, and special hood, helmet, respirators. And, we actually had evidence that those might be more risky, even though they intuitively seemed like they might be safer. And the way that I found most effective to address that was actually to go meet with people. I think that, you can publicly share your rationale as much as possible. But at some point you have to just engage with people and really go find them and hear them directly, hear what they're worried about, and try and show them not just what you're thinking, but show them how much you care about what their fears and what their concerns and what their thoughts are. And I think that was extremely important. I know Katrina did just an enormous amount of that with her department, and I think it's an incredibly important principle to remember.
Well, and maybe Ingrid, I could just add very quickly that actually there's a tremendous amount of social science literature about this. I think we often think that there's only science that we bring to certain types of decisions. But it turns out trust is really created by two domains, by competence and values. And so people trust people because they think they share their values, they have their back, that other type of it, and because they think they're competent. It turns out that if you have a pandemic with a new disease, none of us are competent. And so competence kind of goes out the window, certainly. And so you're left with trust, as Paul says, based upon the values that you show and articulate at all times. And I just think that that is a critical lesson for all of us as we think about these times. It's not about being the smartest person. It's not about knowing more. It's really about leading with values. And as Paul said, for us, those values had to be that we keep the people at the center of what we do at all times.
Dr. Pierre, anything you want to add, or should we?
Sure, I was just going to echo exactly what Katrina and Paul said. It is about competence and trust, as you're saying, and it is impossible to show that. And I think one of the skills there are a lot of leadership courses that do all of these personality tests. It's important to know that as a person, as an individual, you will have strengths and weaknesses, and you can actually learn more about your own leadership tendencies and your abilities. If you know that, be completely aware of that and partner with others who would on your team who would compensate or complement that. And that starts with really understanding how important it is to build trust. And if you're not the best person to deliver message, a piece of the message or to be a part of the communication, make sure that you include those who are needed. So both internally, but look at yourself as a team when it comes to leadership, not just individually.
Thank you. I just want to acknowledge Dr. Klompus, who has joined us, dealing real time with some clusters at the Brigham. I welcome you, Dr. Klompus. We were about to go to student questions, but I wonder if you might want to take 5 minutes just to discuss what's been happening at the Brigham or any updates you wanted to give about the work that you've done as the hospital epidemiologist there.
Sure, Ingrid and Alan. So first of all, thank you very much to be for the opportunity to be part of the class. I really appreciate it, and I'm so sorry. Please forgive me for being so late and for missing this. I was really looking forward to being part of the entirety of the discussion because I really wanted to hear the fullness of what everybody had to say. So please forgive me. As Ingrid mentioned, my excuse is not that dog ate my homework, but that we unfortunately have a cluster of infections of COVID infections right now at the Brigham. I'm not giving you a secret, it's on the Boston Globe. And my job as the hospital epidemiologist is to work on creating policies and procedures and behaviors to keep patients and staff safe. From acquiring infections inside of the hospital. And that has been a whirlwind of challenge and activity for us ever since the start of the epidemic. We began planning for and developing our policies for this epidemic long before it reached the United States. I think we could see the writing on the wall, and have been in really it's just a constant motion of learning what we can from the experience around the world and around the United States, and translating that into an ever-developing mode of policies, and then spreading that out to our staff. And I caught the tail end of the prior comments, and trying to do so in a forthright fashion, being cognizant of what we do know and what we don't know. And I think that as I'm sure you all know very well, what's so very difficult about this particular pandemic is that the nature of this virus is that a lot of the transmission is silent, meaning that people can be infected, can be highly contagious, and feel perfectly fine. And that creates then a challenge, because that means that there could be patients, there could be providers at any time who have the infection, who don't recognize they have the infection, and therefore might be spreading it within the hospital community. So how do we as a system deal with that challenge? I'll say the other thing is that our knowledge about this disorder has changed continually. Just think back to yourself over the experience of the past few months. At first we thought that this might just be limited to China alone, then obviously not. Then people said masks were not too effective outside the hospital, and they most certainly are. And then at first people said steroids are no good for this disease, and then now we know that they are helpful. On and on that vein. It's been a constant mode of change. The infection control program that we've built in close collaboration with our partners from Mass General and from the Mass General Brigham community has been as follows. First and foremost, on the staff side, we need to make sure that staff only work if they're well. That if anybody who is sick, and sick can even be the mildest of symptoms, has to stay off campus. That's because somebody who has even mild symptoms is that much more likely to be a carrier and that much more likely to be a spreader. So daily attestations of health for all employees. Number two is universal masking. Everybody has to wear a mask. That's all employees, and in addition, all patients, so long as it's medically feasible for them to do so. In addition, for our patient interactions, we always wear eye protection as well. Number three, we test every single patient being admitted to the hospital, as well as anybody who's undergoing a high-risk procedure, to try to advance our case finding before they come into our facility. And then when people are identified as positive, we then manage them in a specific fashion, right? We put them into dedicated rooms, have dedicated kinds of personal protective equipment required to look after them. Number three, rescreen every patient every day for new symptoms, so that just in case there was an infection brewing on admission that we didn't find, that was missed by the tests. Tests are good, they're not perfect. We want to catch it as soon as we can after admission. Likewise, if there's a possibility of a spread from a silent staff carrier to a patient, you want to be able to find that as soon as you can. Number 5, distancing. Whenever possible, create distance amongst people. So we've rearranged the architecture of our facilities, as I know you've seen in other kinds of institutions around the city, to ensure spacing whenever possible, barriers when spacing is not possible. We've taken a close look at our ventilation and made sure that that's up to snuff. Hand hygiene and environmental cleaning are the additional components. Then we have a robust contact tracing and testing infrastructure for people who do develop any kinds of problems. So that's our system. I'll say that until a few days ago, it was incredibly effective. We have looked after over 20,000 patients in the hospital, including about almost 1,000 who are COVID positive. And we took a detailed evaluation of the impact on our staff and on our patients. And again, until our issue of today, we'd actually only found 1 instance of a hospital-acquired infection before the current system. So that's a very good track record. It says to me that the system itself is robust. What we are dealing with right now is a cluster of infections. The early insights we have is that this was perhaps brought into the institution by a staff member in their pre-symptomatic period. So the staff member did nothing wrong, but unfortunately that does appear to be a way that is passed to a patient. And then that patient unfortunately passed it to some other patients and then on to some staff members. Why did that take place? Our best understanding right now was because of some breakdowns in those infection control requirements that I outlined for you. And most notably around the use of eye protection for providers and being sure to mask all patients whenever possible. We are also aware that there might be instances where providers outside of the hospital, and I hope not in the hospital, but I wouldn't be able to guarantee it's not happening, might be eating together in unsafe fashion without their masks on in proximity. And so our mission is now to double down on making sure our staff members understand and appreciate and agree with the importance of these measures, and that we can make it not just sort of a set of requirements, but actually an actual behavior, sort of an ingrained natural way of interacting with one another. Okay, thank you.
Thank you. And really, it speaks to the fact that this has continued on, and we're still in the midst, very much in the midst of dealing with this pandemic. So without further ado, and thank you also, Dr. Klompus, for your leadership. I know firsthand how tremendous it's been at the Brigham, so thank you. I'm going to move us now to our students. So we have a bunch of questions, and let's start to pull people up.